Hello, I'm Mike Kontos, the CardioSource Editor-in-Chief for the Cardiac Biomarkers community. Cardiovascular risk assessment based on classic risk factors does not fully predict subsequent risk, which has led to a number of studies exploring the value of adding biomarkers for improving this risk assessment. Probably the best known example is C-reactive protein, which has been incorporated into the Reynolds risk score. However, other studies have found varied results, with some showing biomarkers added no additional predictive ability. Some of the variation in study results derives from differences in the number of patients included, the number of events that occurred, and variations in the biomarkers assessed. To address this, in one of the most extensive studies performed thus far, Blankenberg and colleagues tested 30 different biomarkers to see which, if any, were useful for predicting cardiovascular events. In their study, almost 10,000 individuals were included from 2 different European cohorts. Importantly, patients with known coronary disease were excluded. Patients were separated into a test and derivation cohort, and the ability of the different biomarkers to predict events in the subsequent 10 years was evaluated. The 30 biomarkers that were evaluated represented markers from 9 different categories, including lipid metabolism, inflammation, ventricular stretch, vascular function, oxidative stress, coagulation, renal function, angiogenesis, and myocardial necrosis. The authors found that a number of the biomarkers were significantly correlated with outcomes. After accounting for numerous baseline risk factors, including those included in the Framingham risk score, 3 biomarkers emerged as having the strongest predictive value, all of which reflected different pathophysiologic pathways for cardiovascular disease. Importantly, all are currently available and standard markers in use. These included NT-proBNP, a marker of ventricular stretch, C-reactive protein, a marker of inflammation, and troponin I, a marker of necrosis. Interestingly, these 3 markers were better predictors than any of the newer, more novel biomarkers. In an additional analysis incorporating the 3 biomarkers into a composite biomarker score that also included clinical variables, it significantly improved the ability to predict events over clinical variables alone. This study adds to prior ones indicating that biomarkers have the potential to improve the risk assessment of an individual patient. Subsequent studies will need to address whether this additional predictive ability is worth the cost and determine whether age and gender cutoffs improve their predictive ability. In addition, a key question is defining which, if any, treatments aimed at reducing the biomarkers also reduces patient risk and improves outcomes.